Yes, and thank you for that reminder. We will be recording this session only during the presentation. When we go to questions and answers, Marion is going to stop the recording. So if you do not want to be recorded, please do not ask anything while they are presenting, but please don't ask maybe as they open it up for questions and answers. Just keep in mind, if you do ask a question during the presentation, that may be recorded, but at the end, we will unrecord you. We will turn off the recording. Thank you. While they're getting ready, I want you all to know that the slides are also in the chat box, the PowerPoint slides. So if you're someone that likes to read along with your own slides, you can access those right in the chat box. Marion, did we lose their feed? I don't see Jack on here anymore.
Oh.
Oh, yep, here they are coming back. Hi.
You're muted.
Yeah, we lost our internet connection. I apologize for that.
That's okay.
Let's see if we can get the.
I would have just kept talking.
Well, I was all of a sudden, I was like, they're not really here anymore.
All right, we're back.
Thank you very much.
Cross your fingers. So we're in an old building. Let's put it that way. We're in an old building at Mercy Medical Center in Springfield, Massachusetts. Our inpatient rehab is a 30-bed rehab hospital. The uniqueness to this program, and so that you all can visualize, is we're actually attached to an acute hospital, Mercy Medical Center, via a tunnel underneath the parking lot. So that's, in one way, what made this workable, this performance improvement initiative, the Stroke Alert. We are also, Mercy Rehab is also accredited through the Commission of Accreditation of Rehab Facilities, CARF. We're accredited for both a comprehensive inpatient rehab program and our stroke specialty program. With CARF, we are required to do ongoing performance improvement on a yearly basis. It's really essential for the component of the accreditation process. So that's another reason why, we spend a lot of time in performance improvement. We've also been lucky enough to be participating in this Mass DPH, Coverdell Stroke Systems of Care, really since the onset. So it's been very helpful to us. So looking at this program, some of the best practice, I'm going to have you switch, go to the next slide.
This is what happens when you're.
So some of the best practice guidelines that are spoken about and I learned more about through some of these learning sessions. But obviously, stroke education and post-acute is really important. It's something that we're tracking. So we found we're spending lots of time and energy working on signs and symptoms of stroke, fast education to our inpatient rehab patients, families, our staff. our counterparts, both Patty here in the ED and many of you guys work on the best practice, get with the guideline efforts for the door to CAT scan times, to allow for that maximization of treatment options. So really trying to get there fast enough. And that's kind of what, we were thinking. Mercy Medical Center under Patty's leadership implemented an inpatient stroke alert back in 2013, again, to help ensure that timely diagnostic interventions and treatment options available to anyone in the acute hospital that had an acute stroke symptom. So what we started thinking about when a few opportunities or through a few instances came up in rehab over the past couple of years was that there was really a very varied response in rehab when someone had kind of acute neurological symptoms. There was really, when we looked at it, no formal structure in place or process. It really varied from whatever practitioner was either on the floor or was on a call. So, someone all of a sudden seemed to have more hemiparesis, confusion, dizziness, things that we would say to our patients, call 911. It depended on who was there. Sometimes we found they were ordering CAT scans. Sometimes it was just a regular CAT scan. Some practitioners would say transfer to the ED. If there was medical compromise, they'd call a rapid response. Sometimes it was like, well, monitor them. So there was really no set structure. And, when we kind of had one particular patient, and we did an SBAR on this kind of a Trinity Health thing, this particular patient happened to be almost a year ago in January, and we actually, I think, were attending last January's learning session when we got talking about it, a patient who had a stroke. Her diagnosis, she was 58 years old. She was on our rehab unit because she had a stroke. Her son happened to be with her visiting. This was pre-COVID, and noticed that she was having left facial droop and speech difficulties and reported them to the nurse. One of the problems was it was on the evening shift at 6:30. So the nurse did what she would usually do, and that was call the on-call, both the physiatry and medical teams, and found that she had to kind of wait for the phone call back of what am I doing? Am I sending to CAT scan? Am I sending to the ED? Are you concerned? And the son was actually concerned. So long story short, they did transfer. She finally received the order to transfer to the ED, where a stroke alert was called, and the patient did go directly to CAT scan from the ED. But the time that was consumed was 97 minutes from the onset of stroke symptoms in rehab to the CAT scan. And that's where we all got to talking, is there a way we could make this better? Actually, you can go on to the next slide. We kind of looked at, we did a PDSA, kind of did the Plan, Do, Study, Act for performance improvement. So in the planning phase was really in that Q1, 2020, where we kind of sat down and thought, could we do something with this? And we'll go into this a little bit more specifically. Obviously, the COVID influence during Q2 kind of put a damper on our initiative at that point. So really Q2 and Q3, when we had time, we were recovering from, the COVID, bigger COVID issues from the spring. We were able to work together as a team and our stroke committees, come up with, Patty helped us come up with an algorithm that we'll go over. And we got that implemented, did education. And then the last couple quarters here, we've really, kind of looked at all the stroke alerts that we've now called and what our outcomes have been. So that's what we'll kind of move forward here and review. So I'm going to let Patty jump in, but as part of the larger Mercy Medical Center stroke committee, we brought it to everyone there, and both the EDs there, the medical services there, the neurologist is there, the stroke coordinator, rehab, other members of the system are there, and everyone agreed that this is something we should look into. So Patty here helped us develop this stroke alert specifically to rehab. So I'll let her talk a little bit about that.
So, I mean, basically, we just mirrored what we were doing already in the emergency room or up on the floors for the inpatient stroke alert. So, inpatient stroke alerts, I have a packet that has an algorithm on front of it. So when somebody's having a stroke upstairs, they can just pull it, and it's meant to be like color coded. So as you can see, there's green and there's pink. The green is everything that the provider does. The pink is for the nurse, and then there's a little red line around the CAT scan, just to sort of emphasize that. But basically, you know, we call 4911 here in our hospital in order to call a code. So we tell whoever discovers the patient with these symptoms to call a stroke alert to that room. So over in Weldon, we call rapid response stroke alert. So rapid response brings the rapid response team to the room, and the stroke alert sort of lets CAT scan know that the patient is going to be coming to prep for a patient. Because really the stroke alert in our hospital really only alerts me and CAT scan, because in the emergency room, everybody else is there. So we need the rapid response team to come. And then the provider who shows up from the rapid response team will do an NIH score sort of to see what the severity of the stroke symptoms are. And then order the CT and maybe a CTA, which would tell us if we have a large vessel occlusion on the patient. And then things like checking the blood sugar, keeping the oxygen, getting IVs, things like that is whoever in the rapid response team is able to do those things. The RN should document the last known well time, any medications that were given, especially antithrombotics or anticoagulants. And then stroke history. So somebody obviously has a deficit prior to. So a lot of our patients in rehab may have had a stroke. So knowing what their deficit is and how they're different from their baseline is important. And then the provider is supposed to call a neurologist if they need to determine TPA, but that's usually done in the ER. Basically, the Weldon one, you're getting the nurse or a therapist or whoever sees the change to empower them to call the code team, call the rapid response team to come evaluate this patient specifically for stroke, and then hopefully get the CAT scan before they go over to the ER, and then they can continue on and see what type of treatments the patient will be eligible for.
So once we came up with the algorithm and kind of whose role were what, then we had to come up with kind of an interprofessional team education plan. So on the rehab unit, it was important that we did all shifts because obviously stroke, you know, can happen day, night, and all shifts need to be aware of it. It also had to be interprofessional. Not only did our nurses have to know it, our PCTs, which is kind of our nursing assistants, but all the therapy staff had to be aware of what the new protocol was. We have physiatry staff, we have medical physiatry, we have PAs that come in from that group as well. And on top of that, we have the hospitalist group that's there. So there's a lot of different players. It's a big village, which is helpful, but we had a lot of different players. So one of the ways that we've found in the past to do education is to kind of do small groups, education, committee meetings, team meetings. You know, it meant a couple times I came in at that 6:30 change of shift time, so I could do some personal education with the night staff, kind of hit the evening staff. There's a picture there of my pretty pathetic education board, but it works. So that's one of the things that we did. We also I took the algorithm and the information for the NIHS scale. That's hung on like a D ring right by the code card. It's posted by the hospitalist little section. I have it posted there. We have a nursing substation on the floor, so it's posted there. It's posted in the therapy gym. So I wanted it wherever it might happen, there was an algorithm nearby to help guide it. And that's been helpful. Patty did more, we maybe did combined a little bit from the stroke committee, but Patty also helped with disseminating the message and education with the rapid response team, as well as the ED providers. In the past, when there's a rapid response in rehab, they usually go straight to the ED. So it was getting everyone to change and go straight to CAT scan. So that's where some of that education happened. I did put on this slide down the bottom, you know, because we're attached to the hospital, we don't necessarily have to deal with EMS, but many of these other, one of the other post-acute players that might be on this call may have to involve EMS as well, and should, as well as ED personnel in their hospital, you know, acute care management system that's near them. So we didn't, besides for our ED, but you all might have to also include EMS. So I just want to put that in there. So once we got it going, and the interesting actual thing was, and I happened to be in the outpatient building when it happened, I think it was 1 or 2 days after the rollout, literally we had our first stroke alert. I was everyone was more excited to tell me that it happened, one of those sick things. And I was very disappointed I missed it, but very proud of the team. They literally took the algorithm off the wall. The new medical provider had done a stint in the ED, so he had NIHS on his phone. So that was an exciting thing. But overall, since August, and we rolled this out in August, we went live, I think, maybe August 10th or 12th. So we haven't had that much time. But in that time period, August to December 2020, we've had a total of 7 rapid response stroke alerts. So looking at some of the data, the average time from the stroke alert being called to the CAT scan being done was 41.5 minutes. If you think back to that kind of baseline, that one case that we looked at, we were at 97 minutes. So certainly the total average is much less than that. 6 of the events were 40 minutes or less. We had 1 large fallout that we'll show you in a minute. And we actually had 3 stroke alerts that actually got to the CAT scan in under 30 minutes, which we determined to be a good target time. We based that on, again, tapping into Patty, that get with the guidelines, ED, door of ED to CAT scan is 25 minutes. And we do have a little bit of a travel time. So Patty had us on 5 minutes. Some of us can run that fast, some of us can't. So, but 30 minutes, I think, is a great target for us to hit. 2 out of the 7 events actually, of the ones that were called, were actually positive acute strokes. We've had some other things that mimicked it, UTI, and some pneumonias, some other seizure, but the right thing, I think, was done, and the team was very supportive of that, which again was good, creating a positive culture to move forward. We had 2 fallouts that we'll talk to you about in a minute that weren't transferred straight to CAT scan. They ended up in ED first. One of those actually still made it to CAT scan in 33 minutes. Unfortunately, the other one was a larger fallout. The average time for us to call the rapid response from knowledge or concern of a change in status was 4.5 minutes. And I wanted to highlight that because in the past, the culture was kind of like, find the practitioner, what does that one practitioner want to do? And now we've kind of created a culture to empower everyone. If you think there's a problem, pick up the phone and call the rapid response. So 4 to 5 minutes, I think I'm pretty comfortable with. On average, the last known well time was less than an hour for all of our 7 patients. A couple of these cases actually were in the middle of therapy when they started to have a change in status, so it was almost instantaneous. But we do have a kind of hourly rounding. So on that kind of quality measure, I was happy to see that it was always less than an hour for a last known well time. This is just a slide. On the far left was that kind of baseline patient case, the 58-year-old who had had a stroke and developed an additional stroke when she was in rehab. And it took the 97 minutes to get to the CAT scan. And you can see there, for the most part, the good majority, 6 out of the 7, were pretty close to our target. I think it was number 5, was 33 minutes. That was one of the fallouts that went to the ED first, as opposed to going to CAT scan. And the last patient, number 7, it was the physician's decision, apparently, to go to the ED and not straight to CAT scan. So that is a fallout that, you know, we've done education on, re-education, and we will follow. But we are happy with those results. So some of the takeaways, I'll run through this, and then we can maybe look at some of the chat questions in the chat box. Some of the takeaways, again, we have that looking at our data, some of the new, our protocols, improved the team response. People seem to know what they're doing, everyone's role. Our PCTs are the ones that tend to do the glucometers here, the blood sugar checks. So they're right on it. They know that has to be done. If we have the practitioner that knows the NIHS scale, they're starting that. All the staff know we have to determine the last known well time. They know they're going straight to the CAT scan. We have to move. So a lot of times the stretcher's already ready. Sometimes the patient's right on the stretcher by the time the code team gets there. So that's been something that we've seen, getting people faster to the to radiology. Staff have also verbalized kind of just again a value in being supported in this culture, that they can pick up a phone. Even though 5 of these patients did not have strokes, they were supported, and they really did have neurological signs and symptoms that were concerning for a stroke. So there's been no kind of negative connotations with that, and it's really been an empowering culture. So we will continue to track our outcomes for the established targets throughout 2020, just to kind of see where we're at.
So there's one question in the chat from Mary. Of the 7 patients, what were their admitting diagnoses to rehab? Were there any strokes? There were strokes. Cheryl's got the details.
Yes, and unfortunately, I don't have them right with me. There was a couple patients that actually were orthopedic patients, but had strokes in their past. One of those ended up being a seizure. Another two that had the strokes had actually, their diagnosis were strokes.
One was a bleed.
One was a bleed. So it did vary, but yes, not every one of those were stroke patients that were admitted to us with stroke. Some were orthopedic neurological diagnosis as well. So Patty's going to talk a little bit about, you know, we recognize some of the positive things about implementing this is Patty had already done it in the acute part of the hospital. We're connected by a tunnel, which makes the rapid response team even possible to, you know, sometimes they run through the tunnel, sometimes they run outside. But we understand that that's not the setup for most post-acute facilities. So we kind of tried to put our heads together as how the rest of you might implement something like this. So Patty's going to talk a little bit on that perspective.
So I just wanted to talk about how this does actually benefit the hospital, because obviously the patients come to the emergency room. Usually an assessment's already been completed. Now we still do reassess the patient, but you know what you're looking at right off the bat. CAT scan being performed before they even hit the ER is great, because now you're just waiting for that result, and you can look at the options for care. Now, with somebody who's within 4.5 hours, that might be TPA. They might have a large vessel occlusion. We encourage all the providers, if the NIH score is greater than 6 or they have posterior symptoms, to get a CT angiogram. So we might be sending the patient for thrombectomy if that comes back with a large vessel occlusion. So a couple of options for care for those patients, but also getting verbal communication from the person who from the provider who showed up at the rapid response. So the provider who goes to the rapid response stroke alert actually usually calls the physician in the ED and gives a full report on the patient, what they ordered and what they're thinking. So half of their work is already done, and they can concentrate on how they can care for the patient. So this saves time. Obviously, faster treatment gives better outcomes. But we do recognize that not every rehab is going to be on a hospital campus. And so we do realize that we sort of lucked out because we have a code team on the campus, which has physicians, mid-levels, IV nurses, code nurses, and it can be called 24/7. They're able to assess and order a CT right away. They can give meds like Narcan if they're thinking it might be medication related and see whether the patient reacts to that. We can start IVs right off the bat. We don't need EMS because we can travel through a tunnel to get to the hospital. So we can go right to the CAT scan or right to the ED because it's all in walking distance. And then we're also able to talk about these cases. I mean, obviously Cheryl is able to access me and I'm able to access them, and we could talk about these cases and brainstorm on how to make things better. So how can this work elsewhere? So, I think first is recognizing signs and symptoms of stroke, and not only just the signs and symptoms we all think of fast, but also those posterior symptoms. I mean, lately, I don't know about other hospitals, but I've been getting a ton of posterior, suddenly dizzy patients who have basilar artery occlusions or vertebral arteries, and they're really easy to miss. But knowing those symptoms of the sudden, vertigo or a sudden dizziness or sudden vision changes, but also, hemiparesis and inability to talk. But educating also about the risk factors. So if you have, a certain amount of patients, which ones are at high risk for stroke? Well, did they just have orthopedic surgery and they were off their Coumadin for a while? So are they at risk? Talk to residents and families before the stroke happens about what they want in the event of a stroke. Because I know when I used to work in nursing homes a long time ago, we didn't know. We had to call the family before we could transfer to ask permission to send the patients out. So sometimes you really need to know what they want to do. Maybe they've had several strokes. They don't want care for stroke again. Develop a code stroke. Who can call it? Who is empowered to call this a stroke and then get the help that they need? Who's involved? Are you able to bring in mid-levels? Who can you call? What are the steps? And then, like Cheryl said, don't judge false alarms. Like we've learned this with EMS. We want them to call every stroke that could possibly be a stroke because that's how we're going to catch them all. If we punish anybody or we make them feel bad about calling a stroke that doesn't end up being a stroke, then they're not going to do it next time. They're going to second guess themselves next time. So that's really important. So what are the barriers? So I worked in a nursing home a million years ago, but I know that you could not send a patient out unless it was an act of God. Like you had to get permission from the doctor, you had to get permission from the family. And I know now there's so many bundle payments and things like that. Are there penalties for sending patients to the hospital? And when it's a stroke, you need to encourage people that doesn't matter. Difficulty getting an MD order. So, who do you call for the order to send the patient to the hospital, and how fast do you get that call back? Stroke mimics. Like I said, there's seizures. There's plenty of patients that hemiplegic migraines. Are these people somebody who has those type of things, and when are they having a stroke versus something like that? Code status unclear. Making sure that whether they want to be hospitalized or not. Sedating medications, and then stroke can sometimes not be seen as emergency because it doesn't hurt. People aren't screaming, have stroke. It's usually the absence of things. So even in the hospital, they can easily get missed because they don't yell in pain. It's usually very subtle. All of a sudden, they're not doing something, so it's easy to get missed. Patty had done those slides. I had done a few as well, and we have a little bit of time, so I'll kind of just run through these a little bit. Again, just trying to apply some of the principles to post-acute facilities, but like Patty said, again, just starting with the basics. And I know from our Coverdell involvement, that's one of the big things, just doing stroke signs and symptoms and education for all staff, as Patty said, even looking at some of the kind of less frequently seen posterior, the dizziness, the vision changes, stuff like that. Doing, completing a competency maybe for your staff. Again, just the education on the importance of time. As Patty just mentioned, it's not looked at as a medical emergency. We've had many times where rapid response before wasn't called because it's just like, let's monitor them. Well, time is of importance, we all know, so it is an emergency. Developing a stroke alert for your facility, you know, if you want to take that step, maybe you have an orthopedic wing to start in that from a risk factor standpoint, that might be the more appropriate place to start or something like that. But identify, you know, team leads and responsibilities. Patty said, who are you going to call? Is someone in charge of calling the family, someone in charge of calling the physician, someone in charge of calling EMS? Like, it might, certainly it's going to probably be different than it is in our facility, but really starting to look at kind of laying out what are the responsibilities and who's going to take the lead from them. Draft a protocol that fits your facility. Coordinate, and this is probably going to be real important, coordinate as much as you can with the EMS and the ED. So again, if you have one primary EMS provider, maybe there's someone from that agency that could be your counterpart, and where do they fit into the plan? Are they willing to do that? Are they willing to work with you? Maybe they have some great ideas as well. And maybe reach out to the stroke coordinator at the acute facility that you might send the patient to and see if they have any ideas. Once you do that, it's really, you know, finalizing that protocol and then starting the education process. Once you do that, you could always move into a mock code. We kind of did that as well, just to kind of make sure everyone knows their roles, including, you know, EMS and ED if that's necessary. Assess for a competency, make any changes that you need, re-educate, and provide that positive feedback and encouragement to all staff. Once you go live, make sure everyone knows that you've gone live. Again, have the information available. Patty made and laminated the NIHS scale. We have the cards, which is part of it, the word cards, things like that. So that's in a handy place, kind of right with our AED. Maybe you develop kind of a communication tool that is just even that is helpful for EMS with the last known well time, the blood sugar, the vitals. Maybe that is your stroke protocol and you make that the stroke protocol. But even a kind of a communication tool might be helpful. So if you do that, where are those posted? Are they all together? And make sure it's in kind of a user-friendly place. And the last thing you kind of need to do is really, you know, do that review process, looking back at the data, you know, seeking feedback from all the parties involved, the EMS, the ED, stroke coordinators, but as well as the patient and family. You know, did they feel it was helpful? So that can be really good. Highlight the positives. That's so, I think, so important to the staff. We've had it happen twice during therapy, and the therapists have really initiated the call, and it empowered them. And I can't tell you, they were very excited to know that they had helped in this emergency. So that's been very powerful. So really just monitoring like what we're doing. So
those are some of our ideas. So with that, we've said a lot. I don't know if anyone had any questions.
I was gonna say one more thing. If you are like rehab or post-hospital facility, then also if you're calling EMS, make sure you tell them stroke alert so that they come lights and sirens as well. Because I'd hate to see you, do all this to get the patient ready and then be waiting because you said stroke and they weren't thinking it was a stroke emergency. So saying stroke alert, sometimes at the hospital we'll even say lights and sirens so we get the patient, so we get EMS there right away.
Thank you all very much. This was an excellent presentation, and it's exciting to see the improvements that it's had, and it really, I think, illustrates how Stroke Systems of Care partnership really can dig into something and really make some improvements. So thank you all. Does anyone have any questions? So we're going to stop the recording. I believe that may have already happened. Can you just